This is a video on how to perform a transvaginal scan. My name is Suzanne Johnson and I'm a gynaecologist from Southampton. In the talk we'll go over history, equipment, whether the patient should have a full bladder or not, probe orientation, positioning of the patient and where you should sit, inserting the probe, image optimization, and then I'll show you a systematic scan with stills and videos, and show you how to look at the torus and the posterior compartment, and then a quick report and some take-home messages. Taking a history is crucial. Just by asking the patient a few simple questions, it will give you a much shorter list of differential diagnoses compared to asking nothing. And you can then hunt for specific pathology, really go looking for specific features that would make you think it's diagnosis A rather than B. You of course need a room with a door that locks and a private changing area for the patient, and a bed with lithotomy poles if possible. But otherwise, if you don't have the poles, have the patient at the edge of a bed that breaks so the patient's bottom overhangs the edge a little bit, with a chair for her feet. Have a cover for the front of the patient so she feels more private. Have an ultrasound machine with transabdominal and transvaginal probes and 3D if possible. Probe covers and cleaning and disinfectant materials. You start the examination transabdominally if the uterus is enlarged on examination, or if a transvaginal scan is inappropriate, like a child, or if there is no consent, or if the patient has known fibroids, so you can do a detailed survey with a comfortably full bladder. But everyone else with consent, you would start transvaginally, so most gynae scans are transvaginal only. And you start the examination with the patient having emptied her bladder and no bowel prep. You can, if necessary, do the transabdominal scan after the TV scan, for instance, in case of ovarian malignancy, to assess potential masses and metastases better transabdominally. Probe orientation is really important to being able to interpret what you're looking at. So if we start transabdominally, it's easier to understand. If you look at the probe in the transverse plane, you hold the probe so the marker on the probe is on your left, so you can see a strip that goes across the top of the probe from left to right. So you want to hold it with the strip in this orientation and the marker on the left, on your left. And then you set up the machine so that the marker is on the top left of the machine, which is the patient's right, of course. Then in this orientation, transversely, you put the probe on the patient's abdomen, and the fan of sound that comes out of this grey strip is displayed that way, so that everything from this side goes to this side, everything from here goes to there. If we're now looking at the longitudinal plane, you would rotate the probe 90 degrees clockwise, so that now you've got the patient's head here and her feet here. The marker is now on the upper side, not the lower side, and if you now look in this plane, the fan of sound here is displayed by this. From the marker side goes to the marker side, from the other side goes to the other side, so that if you imagine a patient lying down under your screen with her head at the marker end and her feet there, that's the orientation in the longitudinal plane. So just to show you that again, this is not a transabdominal scan because you can easily see the grey strip that's at the top of the probe. You have your marker on the patient's right, you have the marker on the machine on the patient's right, and then the fan of sound that comes out of the probe is displayed. Everything from the marker side to this side, everything from the other side to this side. So the patient's right will be here and the patient's left will be here. You then go to the longitudinal plane by rotating your probe 90 degrees so that the marker is uppermost at the head end, and then the fan of sound that comes out at the marker end of the probe, it comes to this side and at the other side here. So it's just like the patient is lying down underneath your screen. Transvaginal, it's just the same, but you can't see the grey strip on the tip of the probe so clearly, but if you really look, you might see it, but otherwise look for where the marker on the probe is. So you look at the TV probe in the transverse plane so that the marker on the probe would be on your left side or on the patient's right if you prefer. And then you set up the machine so that the marker is on the same side, so it's on the patient's right, and then you insert the probe into the vagina And the fan of sound is displayed on the screen in the transverse plane. So this would be the patient's right, this would be her left. If you're now with the transvaginal probe, rotate it 90 degrees clockwise, so now the marker is on the top of the probe, the upper side toward the head, then the fan of sound is displayed on this way on the screen. So everything from the marker side goes to the marker side, everything from the other side goes there. So again, it's like the patient is lying down underneath your image with her head here and her feet here. Normally though, you would start the transvaginal scan with the marker on the top. You wouldn't go for the transvaginal view first. You'd have the marker there, you'd insert your probe, and immediately you'd have the head end here and the feet end there. So just to show that again, in the transverse plane with a transvaginal probe, the fan of sound comes out this way and it is displayed marker to marker side, other side to other side. So in a transverse plane, this is the patient's right, this is her left. And in the transvaginal, the sound is coming out like this, and it will be displayed marker side to marker side, other side to other side. So she's lying down. So the image that appears when you're looking at a patient like this, you'd have the bladder at the front, you'd have the uterus behind, the vagina there, and bowel there. So in the longitudinal plane, this is what it looks like. You see the marker is on the top left hand side there. This is the anterior wall of the uterus, this is the fundus, and this is the posterior wall. And you can imagine that she's lying down just underneath there. So this is the cervix and this is the uterus. But in the transverse, again, my marker is there. This is the patient's right and that's her left. And this is the transverse view through the uterus. So how to have the patient lying down? She should be lying down flat and preferably not on a wedge, because patients on a wedge, bottom under the wedge, tips the pelvic organs toward the patient's head and makes the ovaries much harder to find. Better to have the bottom at the edge of the bed, overhanging the end slightly, and then with the patient's legs on stirrups. If she has stirrups, then you sit between the legs facing the patient. That's the lithotomy position, on a low stool on wheels. If you don't have lithotomy poles, have her feet on a chair, and you now need to sit to the patient's right, and this is harder on your right shoulder, but if you don't have lithotomy poles, you don't have them. And I like to have the bed relatively quite high with sides up so they can't fall off, so the patient is level with your upper abdomen. And then you hold the probe with your right hand and use your left hand to control the machine. I like the room quite dark so I can see the screen better, but I have at least one light near the patient. Cover her for privacy and use plenty of gel on the outside of a covered transvaginal probe. You don't need to put extra on the inside or on the outside, just plenty of gel. And then gently, gently, gently is the main thing I'm going to say about this. Explain what you're going to do and make sure your patient is consenting to it. Make sure her name is correct on the screen. Warn patients in advance that if you're quiet, it just means you're concentrating. And what I always say is, I'm so sorry, but I can't talk while I scan, because I literally can only do one thing at a time. The next instruction I give is, please put your arms by your sides, let your bottom sink into the bed, and let your knees go floppy. And this works every time. And then you can gently and slowly insert the transvaginal probe. You angle it at about 45 degrees backwards toward the sacrum, following the line of the vagina. Now you'll be in the longitudinal plane, so you have your marker on the top side of the probe, and you orientate your image accordingly. If it's difficult to insert the probe, reassure the patient, make sure she's still consenting to what you're doing, and put extra lubricant on the outside of the probe. Don't say relax, because it means absolutely nothing, but say again, put your arms by your sides, let your bottom sink into the bed, and let your knees go floppy. Encourage the patient to take some nice slow deep breaths, and then gently press with the probe after each second or third deep breath. And use gentle pressure toward the sacrum with a little bit of axial rotation to left and right, a bit like doing half of a corkscrew. And don't press hard, because the muscle resistance may suddenly give. And stop if the patient's in discomfort or if there's a suggestion that consent has actually been withdrawn. You can always stop and try a transrectal scan if the patient is happy with that, or transabdominal, or offer to rebook the patient for another day or with another clinician. During the scan, watch the screen all the time and the patient's face regularly. Carry out the systematic scan and then at the end, gently assess for mobility and tenderness. And take representative views as annotated stills and video clips. And be slow and gentle, that's the most important thing. Image optimization I'm not going to talk about, we'll do that in a different video, just to be aware that these are all things that you may need to change. And then the scan is systematic, it's the same every time. You start by looking at the introitus, then at the bladder, uterus and cervix, endometrium, the ovaries, and the pouch of Douglas, free fluid and sliding sign. And these are absolutely essential every single scan. Mobility and tenderness too. So during a systematic scan, from the perineum you gently insert the probe into the introitus and then gently advance the probe to the top of the vagina, angling the tip toward the sacrum. And you follow the urethra. If you can find nothing else, the urethra will be right in front of your probe. Follow that to the bladder. And then you look at the bladder in longitudinal and transverse planes. Identify the uterus and cervix. They're both behind the bladder, so they're toward the right side of the screen. Then look at the uterus, do a slow sweep from one cornu to the other in the longitudinal plane, looking at the myometrium, and then repeat that to look at the endometrium. Now move the tip of the probe slightly backwards toward the patient's sacrum to look at the cervix and examine this in sweeps in the longitudinal plane. Now rotate your probe 90 degrees anti-clockwise and you're now in the transverse view. Sweep in the transverse view from cervix to uterine fundus and come off the top to make sure there's nothing pedunculated there. And then in the transverse plane, slowly sweep down to include the cervix again. I go back to the longitudinal plane to find the ovaries. So in the longitudinal plane, I look at the fundus and I aim the tip of the probe at the uterine fundus. And then, keeping my elbow still, I move the probe laterally along a horizontal line from the uterine fundus. And then just at the end, slightly externally rotate my hand, whether I'm doing the right or the left side, slightly externally rotate my hand, and then you will get a view of the internal iliacs. This is the view you'll get, and this is a nice landmark of the vessels and the ovary just in front. If you can't find the ovary in this plane, then try the transverse plane. Get a transverse view of the uterine fundus, move the probe laterally along a horizontal line with the fundus, following the ovarian ligament, while slightly going up and down, up and down, up and down like a mermaid swimming, and then dip down slightly laterally to see the ovary. And this is a view that you would get of the ovary seen in the transverse plane. Sometimes you can see a circle of the internal iliac vein, but you can't always. So there's no landmarks to see. And sometimes you might need to gently press with the left hand on the abdomen to displace bowel and reveal the ovaries. And then lastly, in the longitudinal plane, you'd look at the pouch of Douglas. So you tip the tip of the probe backwards to look behind the cervix. So if we start by looking at the introitus, you place the probe on the perineum, so the probe is just here, and you orientate yourself. Be sure that the marker on the machine is there and that the marker on your probe is uppermost. And what you'll see is the urethra, and then behind that is the vagina, and behind that is the anal canal. Very slowly insert the probe. It will go in this way with the anterior vaginal wall here and posterior there, and you can just follow the urethra until you get to the bladder. Do it very gently, watching the screen all the time, and then you'll probably be in the anterior fornix. So again, this view here is urethra and bladder. And you need to comment on whether there's any residual volume in the bladder after emptying and whether the bladder wall itself is normal. And you can look again at the bladder at the very end of the scan because there'll be some urine in there by then. So inserting the probe, we have the urethra here. This is going to be bladder, anterior vaginal wall, posterior vaginal wall. This is the vagina, and then here is the anal canal. So we'll see what that looks like. You can see as we're going down, we're stretching with the anterior and the posterior vaginal walls until we're onto the cervix. Anterior wall, posterior wall, then this is the cervix and the uterus. Ignore that. There's the bladder. That was a bit of endometriosis. So that's inserting the probe, looking all the time. Look at the bladder. So what we're going to see is the urethra. We're going to see the bladder. That's a ureter coming into the bladder, and that's a bit of uterus. So we're now going to go from side to side on the uterine bladder, looking for any abnormalities. And you can often see, like there, you can see the ureters come into the bladder. That's one ureter coming into the bladder in the longitudinal plane, sweeping from side to side. And there is the other one. So looking at the bladder. And what you might see, this is the ureter as it's entering the bladder. You can see vermiculation. This is completely normal. You can see how the urine is entering the bladder at the trigone. And this is a transverse view of the same thing, just to show you. This is the right ureter, and this is the left ureter. You can see with a bit of colour Doppler that she's well hydrated. So when you're going to take some stills, this is a still of the uterus. So you need to say whether the uterus is anteverted or retroverted or axial, and if there's any fibroids or adenomyosis. So you can see this is the cervix, this is the anterior wall, fundus, posterior wall, and this is the endometrial cavity. So the position, this is anteverted with the uterus tipping toward the bladder. This is retroverted with the uterus tipping away from the bladder. This one is anteverted and retroflexed, and you see that when there are posterior adhesions pulling an anteverted uterus backwards. And this is axial, which is quite common in older patients where the uterus is in a straight line with your sound waves, so it's sometimes slightly harder to get a good view axial. So we're now going to look at the uterus in the longitudinal plane. I'm going to sweep in this plane from cornu to cornu. So you can see there's the cervix, this is anterior wall, posterior wall, and I'm just going from one cornu to the other. And you might want to repeat that a few times, particularly if there are some abnormalities. And you can see the cervix is just there with the cervical canal. So in the longitudinal plane, you would take the length. Normally what I do is I aim for fundus, and then I go to about there where the angle changes, and I measure the cervix as part of the uterine length. So I'd have to take a second view here, and then at 90 degrees to this line I'm going to do the depth. So this is length and the depth. Then I'm turning my probe 90 degrees anti-clockwise, so the marker is still here and the marker would be on this side on the probe, patient's right, patient's left, and at the widest part take a width. Now I'm going to show you in the transverse plane from cervix to fundus. It's just another way of looking at the uterus. There's the cervix and there is the uterine fundus. You can see that the endometrial cavity was very slightly splayed, so we'll just do that again. From cervix in the transverse plane, following the endometrial cavity to the very fundus, and then back down again. So we've seen the uterus in two planes now. Then I'm going to look at the cervix. So what you can see, my probe is here in the anterior fornix, and this is the anterior bit of cervix. This is more or less the internal os. This is the cervical canal. You can just see the posterior vaginal wall there too. So you need to look at abnormalities in the canal as distinct from abnormalities in the stroma. I always put colour on just to make sure I'm not missing a lesion in the stroma with abnormal vascularity or missing a feeder vessel in the canal. I'm going to look at this cervix in the longitudinal plane from side to side, just as though it was a uterus. And this is the posterior vaginal fornix, and you can see that my probe is in the anterior fornix. There's a bit of cervix, a bit of vagina just behind there. So we're in the anterior fornix, and I'm going to sweep from side to side in the longitudinal plane. So that's the cervix. I'm getting to see it very clearly, make sure there's no abnormality there. Next, I'm going to look at the endometrium. So again, it's a longitudinal view of the uterus. The internal os is about there. You can see that where the bladder attaches, that's about the internal os. And then this is the endometrial cavity. And so what I need to do is measure the endometrial thickness from outer to outer at right angles to the uterine length. And then make a judgment. Is it in the follicular or the luteal phase? And is it regular? Is it normal? So in the longitudinal plane, I'm going to sweep from side to side, from cornu to cornu. So you can see there's the ovary peeping in, and you can follow this endometrium very clearly as I'm going from one cornu to another. just do that again, just looking at the endometrium, only looking at that. And then the other cornu, and then back to the center again. So now I've really seen the entire endometrial cavity clearly. Next, I'm going to look for the ovaries, and I like to do this in the longitudinal view. So what I'm going to do with the tip of my probe is look for the uterine fundus, then keep my elbow still and move my forearm laterally to the internal iliac vessels along a straight line. So you can see I came off the uterine fundus, and there is the ovary with the internal iliac vein and the artery. So we'll just do that again, longitudinal uterus, move laterally at the level of the fundus until you reach the pelvic side wall, externally rotate your hand a little bit, and then no matter if you're in the right or the left side, you get the vessels in that orientation. You can see it's just there. And this is a really good way of finding the ovary. So you've got the internal iliac vein and the artery just there. You've got the ovary just in front of it. If you can't find the ovary in the longitudinal plane, look in the transverse plane. So again, you need to aim for uterine fundus, and then this time draw a horizontal line with the fundus and follow the ovarian ligament. In this video, I'm going to start longitudinal, then I'm going to go to transverse and move up to the ovarian ligament. So that's my longitudinal. I'm going to go transverse, up to fundus, and there is the ovarian ligament. And you can follow that out by dipping your hand up and down a little bit if you lose it, and there is the ovary. So we'll just do that again in a minute. Longitudinal view of the uterus, aim for fundus, go transverse, interstitial portion of fallopian tube, ovarian ligament. There it is again, ovarian ligament, and there is the ovary on the end of it. Harder to do in some people. You don't have the same landmarks to prove that you looked in the right place. And it's the ovarian ligament, it's not the fallopian tube. And you can follow it by dipping down your whole hand slightly as you go laterally. So that's the view you'd get. You might get to see the internal iliac vein, or you might not. It's just a harder view to get, and if you don't see the ovary in here, you can't prove that you looked in the right place. Whereas at least if you've got the longitudinal view with the vessels, you can say, I looked in the right place. But essentially, it's really valuable to learn both ways and just practice it on patients in whom there's not a lot wrong, and before you know it, you'll be able to do it. When you find the ovary, you rotate on the ovary to get the longest length. So I found it, and I'm going to rotate my hand till I find the longest length. That'll be the length, that'll be the depth, and then I need to rotate my hand 90 degrees, and that's the width. You then need to comment on where the ovary is. Is it in the ovarian fossa where you'd expect it, or is it in fact glued to the back of the uterus? Is it normal in size? Is it active, or is there atrophy? Are there follicles, particularly if you're doing a fertility scan or thinking about polycystic ovaries? Is there a cyst or a mass, and how mobile is the ovary? In this case, those little follicles, so you need to take at least one measurement of it, and then put some Doppler on, looking in this case for peripheral vascularity, looking to see, is it a corpus luteum? Then you need to go in the transverse plane. So here is the ovary, and this is the edge of uterus. You need to look in between the ovary and the uterus, make sure there's not an ectopic pregnancy or other pathology hiding there. They're also going to judge mobility and anything else in that view. Do the same for the right ovary. This is the longest length, and that's therefore the depth. You rotate at 90 degrees to get the width. And again, you assess whether there's anything between the uterus and the ovary, if there's anything in here that's not normal. And you need to judge whether the ovary is mobile. You may need to put your left hand on the abdomen with the right hand obviously holding the probe. And this is a supermobile ovary, and it's very easy to see. Most ovaries are not as compliant as that. A good time to judge mobility and tenderness is at the end of the scan if somebody is tender. If they're not noticing anything at all, then you can judge it. Mobility at any rate at this stage. And sometimes, particularly if there's fluid in the pelvis, something else pops up, and that's the fallopian tube. That's a normal looking fallopian, that's a bit of bowel, normal looking fallopian tube. So you can see these sometimes, but usually only the fimbrial end. And then look at the pouch of Douglas. You haven't finished just because you found the ovaries. Again, we're in the anterior fornix. This is the anterior cervical lip, posterior cervical lip. This is the back of the cervix. And you need to look for free fluid in the pouch of Douglas, and also look at the sliding sign. Now, how to do the sliding sign, it matters where your probe is. So in this example, in an anteverted uterus, this is the anterior fornix, and this is the view you get. You can see the cervix, and so you can also see the sliding sign, which just means the mobility between bowel and cervix. If in an anteverted uterus you put your probe in the posterior fornix, then you can't see the cervix because it's been pushed out of the way. You can see it just there. There's the posterior cervix, so the attachment would be about there. But it's a great way for looking for bowel nodules and adhesions, especially endometriosis. In a retroverted uterus, with the uterus tipping toward the feet, if you have your probe in the anterior fornix, you can see the cervix clearly. If you put your probe in the posterior fornix, you can't see the cervix, it's been pushed away, but you can judge the sliding sign here at the back of the cervix very nicely, and of course see bowel nodules and adhesions. So we'll do some examples. This is an anteverted uterus with the probe in the anterior fornix, and this is a lovely sliding sign. So you can see here, this is all bowel, and it moves beautifully against the back of the uterus there, back of the cervix. You can see almost bowels going one way, uterus in the other. You don't want the whole thing to move together. That's not a sliding sign. These have to be moving against one another. In a retroverted uterus, we're in the posterior fornix now. You can see a little bit of fluid in the pouch of Douglas. And here you can see that by pressing now, I can see beautiful mobility. There's no adhesions there. Looking at the torus, it's really important. If you look at a longitudinal view of the uterus, you'll probably be in the anterior fornix. You look to see where the bladder attaches to the uterus. Then you draw a line backwards, which includes the internal cervical os and then the torus on the posterior uterine wall. You then rotate your probe 90 degrees anti-clockwise and be sure still to be at the top of the cervix, where the endocervical canal is narrow and circular, not linear as the endometrial cavity is. This is the torus, so this is where the uterosacral ligaments attach to the back of the cervix, and this is usually the center of deep endometriosis. So you can look for nodules of endometriosis. And if you move your probe in the transverse plane slightly toward the right, you'll see the right uterosacral ligament, and on the left you'll see the left uterosacral ligament, and I'll show you a video in the next slide. Then you move your probe into the posterior fornix, and the uterosacral ligaments are now stretched over the probe, and you will also be able to identify bowel deep endometriosis more easily. So I'll show you. This is a longitudinal view of the uterus. So this is the external os, this is the cervical canal, this is the endometrial cavity, and that's the anterior uterine wall. Fundus is up there somewhere, and posterior wall, and the back of cervix. And the posterior vaginal fornix is just there. We're going to look to see where the bladder, this white line here, where it attaches to the uterus. In a straight line back, you've got the internal cervical os. In a straight line back, that's the torus. And so this is the area that we want to look at. And I'm going to start in the longitudinal plane, and then I'm going to rotate my probe to the transverse plane, so 90 degrees anti-clockwise. So longitudinal plane, slightly side to side, rotate the probe anti-clockwise. This is now the torus, and this is the right uterosacral ligament, and this is the left. So quite hard to see because they're so nice and normal. It's hard to see them when they're nice and normal. So transverse, that's the torus, and then these are the uterosacral ligaments, very thin, fine white lines, and if everything's moving, gliding nicely, then they're normal. And at laparoscopy, when we do a laparoscopy, the patient would be in this orientation. We look into the abdomen this way with the patient's right on the right side of the screen. So we're looking here at the back of the uterus. This here is the torus, And this is a uterosacral ligament, the right one, and this is the left uterosacral ligament, and where they join onto the cervix is here, and this is where you get endometriosis. And this is the pouch of Douglas. You can see there's nothing wrong there. Back of uterus. So if you remember that picture, this is a retroverted uterus. It's tipping toward the patient's feet. Here you can see the pouch of Douglas with a little bit of free fluid. My probe is in the posterior fornix, and you can see some dark vagina. Then you can see white. This is peritoneum. And then in a minute in this fluid, you'll see a normal uterosacral ligament. And as I press harder with my probe, that uterosacral ligament becomes blended onto the peritoneum. So that normally when you're in the posterior fornix, the white line you see is a combination of peritoneum and uterosacral ligament. So let's have a look. That's the uterosacral ligament. Now it's being stretched over the posterior vaginal fornix. And there I'm letting go again. So it's free fluid. That's the uterosacral ligament being pressed onto the posterior vaginal fornix and then letting it go again. So it just proves to you that there are two different ways of looking at the uterosacral ligaments. One is in the transverse plane at looking at the torus, and one is in the longitudinal plane with a probe in the posterior fornix, stretching that ligament up and over. Next thing, we're going to look at the posterior compartment. So what you need to do is put the probe in the posterior fornix, because as we've shown, if it's in the anterior fornix, you can see the cervix, you can see the sliding sign, but you're not going to see what's behind there very clearly. To do that, you need to put your probe in the posterior fornix, both for an anti and retroverted uterus. You now can't see the cervix, but you can see bowel nodules and adhesions. So how to do that? Here is my probe in the anterior fornix. This is the anterior bit of cervix, posterior. This is the external os. This is the posterior vaginal fornix here, posterior vaginal wall. And here more or less is the internal os. So this is the cervical canal, and this dark is just a bit of mucus within the cervical canal, making everything so clear. So what I'm going to do, I'm going to start my scan in the anterior fornix, then withdraw the probe slightly, angle the tip of the probe backward toward the sacrum, and then gently insert it into the posterior vaginal fornix to have a look at this area in more detail. So here's the video. You can see the posterior vaginal wall really nicely. I'm taking the probe out and now gently reintroducing it a bit. Posterior vaginal fornix, and now I'm in the posterior fornix with a little bit of fluid in the pouch of Douglas. So we'll just repeat that one again in a moment. There, it's coming out again. So we start in the anterior fornix. We're going to withdraw the probe slightly into the vagina, backwards a little bit, and then I'm going to tip my probe backwards to the patient's sacrum, tip of the probe toward the sacrum, and then very gently introduce it into the posterior fornix. And all the time I would be saying things like, let your bottom sink into the bed and let your knees go floppy, because if the patient doesn't relax her muscles at this point, you will not get the probe in the posterior fornix. And you need to be super gentle. It doesn't have to hurt, it really doesn't. When you're in the posterior fornix, you can see a little bit of free fluid. This is the posterior vagina. This is the peritoneum with the stretched uterosacral ligaments, a little bit of free fluid, and then bowel. And the bowel has got lots of different layers, and you can recognize those readily. So the first one, very echogenic, is serosa. The next one is dark white dark. Now this is a longitudinal muscle layer. This is the circular muscle layer with a bit of connective tissue in between. This is the muscularis layer, and it's crucial to understand this for the understanding of endometriosis. Then here we've got submucosa and mucosa together, all hyperechoic, white. We've got the same on the other side with the lumen just in between. Then we've got muscularis again, and then we've got serosa. And so the lumen of the bowel is here in this direction going toward the anal canal. So this is what normal bowel looks like in the posterior fornix with your probe in the posterior fornix there, in the pouch of Douglas. So a systematic scan took in the bladder, the uterus and cervix, the endometrium, the ovaries, pouch of Douglas, looking at free fluid, sliding sign. For more advanced, you'd look at the torus and the posterior compartment. and then judging mobility and tenderness at the end of the scan. Then in your report you would say what history you took, how the examination went, what you saw and what you think is going on. Give an impression and then explain the findings to the patient and include a little cartoon if that's helpful. For instance, fibroids, polyps or endometriosis, a little cartoon means the world to the patient. They can just suddenly visualize what you've been looking at. And don't forget to save your images, of course, it's very important. So the most important things are patient privacy, patient positioning, and patient comfort. Always be gentle and actively look for pathology. Look to include or exclude the differential diagnoses. Thank you.